unfortunate, but where do you go? Many people choose to go to the emergency room because their primary care physician, his office is closed. But this actually has led to a huge problem. In fact, $38 billion are lost every single year due to patients with non-acute medical needs overutilizing the ER. These patients typically fall into two categories. Either patients who simply don't have the knowledge of where else to go at that hour, or patients who are uninsured and don't have other means of finding cheap alternative forms of care. This has a huge impact on waiting times, as you can see. 2 hours as a median wait time is immense. That's 2 hours too long if you have a real life-threatening emergency. But don't worry, there's a solution. So we see that there's a potential for $4.4 billion to be saved by simply redirecting these medical needs that are non-acute, so redirecting these patients away from the ER to other forms of care. And we're not the only ones who've been thinking about this. In fact, we spoke to the head of a huge campaign in Washington State that by simply redirecting 14% of these cases, they saved $30 million already. So that's where we come in. I'm Ayushi.
I'm Theodore. I'm Andrew.
And we're PulseLine. We automate triage questions so that we can redirect patients with non-acute medical needs to other forms of care that are just as both good or effective, but that are going to be quicker and are going to be more cost effective, such as urgent care and outpatient care clinics. Our core technology, as we've demoed here, for our MVP is actually implemented through a simple questionnaire, in our case, a type form. We have literally taken word for word questions from triage. Like if you walk into a high volume triage, you will answer the exact same questions. So we're automating that, and we're asking you to do that before you even get there. Now, our primary user is not someone who is having a heart attack. They call 911 and get an ambulance. We're focused on the user who has a sort of non-acute medical need but doesn't know where to go. And this is how they use our product. So first, they go to our web application, PulseLine.com. Then they would normally have gone to an ER, so they will go ahead and select that there. But before we allow them to be queued for the ER, we ask them to fill out this questionnaire. And we've tested it. It takes 3 minutes and 58 seconds to fill out. Super quick, super to the point. You can do it on your phone, laptop, tablet, all of the above. Then we take existing algorithms and we apply that to give you an immediate feedback. And so we either direct you to an emergency room or other means of care such as a close outpatient clinic. And we will automatically add you to the queue.
So how do we actually make money with this? Well, PulseLine is a software as a service venture that reduces ER overutilization and overall wait times. We have talked to doctors from CNMC Medical Center in Washington as well as Penn State, and we have figured out that the best way of reaching out to hospitals and patients is by having a subscription-based model. So we are going to bill hospitals monthly a flat fee calculated using the money that they're losing on average with patients that use the ER non-appropriately, together with taking into account what the competitors' costs are. At first, we will target large hospital systems that have both the ER and outpatient clinics. We have already found one such system, Erlanger in Tennessee, and they have as well identified ED overutilization as a big problem. Afterwards, we're going to target hospital systems in states where ED overutilization is identified on a state level basis. This means Maryland and New Jersey, and we already have some contacts there that will allow us to pitch directly to hospitals, and they recognize the need. Go ahead. So we have 3 pillars that will ensure that our go-to-market strategy is successful. The first pillar is direct sales, and that's when we'll come in during the first year. As founders, we'll go directly to hospitals in order to talk about our product and ensure that we have at first a test in a hospital system like Erlanger, and then afterwards move on to others. In the second year, we will hire direct sales representatives who will help us reach out to more hospitals in order to reach out to more patients as well. The second pillar is targeting insurance companies because they are actually dealing with a lot of these costs in the first place. They have to front them. So we wanna partner with insurance companies that have identified ED overutilization as a problem in order to reach more hospital systems. And last but not least, the third pillar is hiring and putting some money into search engine optimization, because we believe that we can successfully increase our chances of getting an inbound sale by having an active presence on the internet, since a lot of states and a lot of hospitals are actually concerned with this problem, and they might just find us as a solution. In terms of our competition, we've done some extensive research, and we found two main competitors that validate our business. The first one is Team Health Medical Center. They have a group of nurses via phone that do the triage. They're not especially effective because they have a lot of costs with the nurses, but they do validate our need for triage outside of the emergency department. InQuicker is another main competitor. They sell a product that has a virtual waiting room. As a result, they validate our virtual wait concept, which is implemented in our product. However, they're not doing any triaging, and they're not automated, and they're not really solving the problem of ED overutilization. The last two competitors that include there are WebMD and Boy Health. Boy Health has a nice approach to healthcare that uses chat, a nice user interface, in order to diagnose patients. We don't want to go into diagnosing patients, but we really appreciate the concept of offering empathy through a nice user interface. And this is something that we'll certainly implement after our test in our second year. And again, last but not least, WebMD is known by everyone, and we included it as a competitor because we realized that they validate actually that there is a need for people to do self-service in the healthcare business online. And even though it's not right for people to self-diagnose themselves using WebMD, and that leads to a lot of problems, they validate our market pool. So that's where we come in. We take the best of what everybody has to offer, and we put it together in order to reduce this one focused goal, ED overutilization.
And we see two main strengths to our team. We have substantial technical experience. Between us, we've worked at large companies, mid-sized companies, and startups. And we've also led teams through Entrepreneurship Club, which have cumulatively raised over $100,000 and led 50 people. But we do recognize there is an experience gap in our current team, which is why we've already recruited an advisor who's had 3 successful startups, including one that was acquired for $10 million. And we also want to use a lot of our initial funding to hire consultants and a VP of engineering to help us build and validate the product to make sure that we are able to scale it. And so in the first year, we'll be building out the product and working to make sure that it is validated. We address our main concern of false negatives. And the primary way we're addressing that is we're using existing triage questions that hospitals are using right now. We're not implementing anything new. We're taking what they would ask you in a hospital to see if you do belong in the emergency room and putting it so patients ask those questions before they get there. And after that, we'll initially have 2 hospitals and scale the system there and validate that the infrastructure and questions that we use are able to scale before hiring a sales force or a Series A expanding more aggressively.
Almost out of time. Is that it?
Yep.
Okay.
Thank you.
Thank you very much. So I believe in the problem, and I think it's great that you've taken the steps to put together kind of an initial product, but it seems fairly lightweight. So what do you view as that kind of long-term competitive advantage that is really going to be that moat to separate you from future competitors?
I can take that. So this is our MVP, and basically we want to validate that people would actually use this in hospitals. There are some barriers that we want to make sure that we can go over. But afterwards, we want to go towards using a chatbot-based system that actually asks these questions and is aware of the way that a patient is talking through him, which is going to offer us basically a lot of information as well as a way to directly interact with the patient. And moreover, the aspect of having a virtual queue is going to be extremely helpful in gearing this towards hospitals. So this doesn't have a virtual queue at this point because it would be impossible to implement it. But we've noticed that what InQuicker does is actually fairly successful, and we want to kind of enhance that using the ER triage beforehand.
To add on a little, the Typeform was created to give you an idea of the questions that we ask, how easy it is to fill out, this isn't something that would be part of our initial trial. That would be a website and a system that we build to ask the questions.
And in terms of content, I know it does seem pretty lightweight, but we have taken literally word for word. There is something called My Smart Tag that high volume ERs use. Like we've gotten ER physicians to send us legitimate pictures of these. So these questions that you see on here, word for word, what you would be getting when you walk into triage.
Yeah, I guess that still troubles me a little bit. It seems to me that the team health approach, which is to use nurses to do the triage, that you want to have a medical professional in the loop somewhere. I'm a little nervous, and I think it's going to be a high hurdle if you take a medical professional out of the hurdle. I mean, I don't know what the regulatory areas are. So, I mean, to me, I'd rather have in the ER, the triage questionnaires are then reviewed by medical professionals, and you're sort of eliminating that step. So
Right.
that's
So,
tricky.
yeah, to address that in two different ways. First of all, the answers to this questionnaire are calculated and called something called a Glasgow algorithm, which is literally a score, like based on the numbers that you saw, especially like under coma, literally called a Glasgow coma score. And based on that, we're not necessarily telling you what you have. We're just categorizing you in a red, green, yellow, which is word for word, like exactly what happens. Like if you're 12, 11, or 10, that is how they're going to redirect you at the hospital. Now I agree, okay, so do you need a physician to tell you if you can see? Like these are all questions that nurses are literally asking you. Can you see? Do you feel like, does your head hurt? So in that case, for the very first step, a physician is not needed, and we've talked to physicians everywhere from Washington to Nevada to Tennessee, and they've all said, yes, that very first step is done by nurses, but it's all based on what the patient tells you. So does it matter if you're paying a nurse to write that down, pen and paper, or does it matter if you're doing it in your bed on your phone? So that's like, to answer that part. And the other part is eventually we want to integrate some sort of AI bot for a little more advanced, but in terms of like, first step when you get to the door, that triage questionnaire is exactly what you see in front of you.
To add to what she said, I think one of the doctors that we talked to mentioned that people literally have a high schooler doing this. Every other life example.
It has to be a doctor, but I guess.
Yeah, and so to add on, we are very concerned about false negatives, which is why we would be very conservative in these evaluations. And there are main cases that we identify, specifically injuries like broken bones or people that have colds that go to the emergency room that clearly do not need to be there. And those are the cases we're targeting with this. Borderline cases, we will be conservative and send to the emergency room.
And we've actually been given by a couple physicians have compiled a list of like the 10 top non-acute medical cases that are seeing the ER, and specifically an algorithm of sort of like hierarchy tree diagram. And so we weren't able to convert that into another MVP, but eventually we want to include that in our data.
Okay, great. Thank you very much.